It says it's...
Just hold off for a second because I haven't started the webinar yet. Okay, we are live on Facebook, so I'm going to start.
Hello, folks, and welcome to our Monday morning webinar. I'm Aamer Khan, and I'm the editor at Aesthetic Medicine. Welcome to our webinar in partnership with 𝘱𝘕𝑚𝑒𝑡𝑖cs on fat, micro and nano grafting safely and consistently. Today, I'm really lucky to be joined on my call with Dr. Aamer Khan, who's a leading expert in cosmetic and non-surgical procedures. Dr. Khan became a full-time cosmetic doctor in 2005. He's the co-founder of the Harley Street Skin Clinic with his wife, Leslie Reynolds, and he is also the author of an internationally acclaimed textbook, Regenerative Medicine in Aesthetic Treatments. So, Dr. Khan, I'll hand over to you to tell us all about fat, micro and nano grafting this morning.
Good morning. Thank you very much. Thank you, Anna. This subject it's a really important subject, close to my heart. It's something that I've been really interested in ever since my training days back at university. So what I'd like to do is start off by a little bit of educational content, and then we're going to move on to talking about a particular technology that I'm using myself at the moment, and I'm finding it really useful. I've been around this sort of fat grafting arena ever since 2006, and this technology was first introduced to me back in 2008, and then it's evolved and been developed, and obviously it's gone from hand to hand from one company to another and developed further, and now it's presented in a really easy to use way. So I'm going to be talking about that in a minute. So if we go on to the next slide. There's a little bit about me. So Anna's already introduced me and said most of the things you need to know. So if we go on to the next slide. Okay. Now, the equipment I'm going to talk about is equipment we use. I'm not associated with a company. I'm not a KOL for them, though I use the equipment when I do training. Because it's the equipment that I use, and I've used other equipments as well. So it's important to get that across, that I'm not financially associated with the company. Next slide, please. Okay, regenerative medicine. It's really exciting where this is going. It aims to restore cells and organs back to their original healthy state. Now, in aesthetics, we can use this. It's obviously used in medicine. And it's something that's really taking off. A lot of work is being done on it. And our knowledge about cellular regeneration is increasing at an incredible rate. Now, 200 years ago, the average lifespan was about 40 years. And now, because of science, because of medicine, and the NHS has done a fantastic job in preserving life and allowing us to live longer. Ever since antibiotics came in, we've been able to overcome things which would have taken us at a younger age. So now life expectancy is about 80 plus. Now that in itself brings its own problems. The National Health Service and the health services being so successful have created their own problems, in that now we're seeing diseases and conditions which are related to the aging process. So most of the conditions that are being treated within the National Health Service relate to the natural aging process. And that's the natural degeneration as a result of our environment. So what we need to think about is lifespan versus health span. And there is that discrepancy at the moment. There is a gap between the lifespan, which is our life expectancy, and health span, how long we expect to be healthy and to be able to do what we want, when we want, for as long as we want to do it. And regenerative medicine is addressing that gap, and that health gap is becoming narrower and narrower. Yes, we're living longer, but we're living better. And there are lots of factors which come into this. Next slide, please. Thank you. Now, the human body in itself is an incredible organism. Allowed to do what it should do, it will solve most problems. Now, we're all made up of cells, and there is an estimated 32.7 trillion individual cells that make up the average human body. And this varies, obviously, from size to size. We're talking about average, and this figure is an estimate, and we're finding out more and more about this. Now, all the cells in the body have the ability to communicate with one another through microscopic signaling proteins called cytokines. And we've all heard about cytokines, and most recently, with respect to COVID. And when we talk about cytokines, there's a degree of fear around them because of the cytokine storm. But cytokines can be good, they can be bad. All they are doing is giving instructions. And if those instructions are to regenerate and to heal, then that's good. If the instructions are to create more inflammation and to create chaos, or there are so many cytokines around that the cells become confused and don't hear the proper cytokines, then that can create a problem. And that's the problem we saw with the cytokine storm in COVID. But this has already been documented before under different terminologies, post-viral crises, sepsis, it's another name for the same sort of problem. So these microscopic messengers determine how we feel and how we function, how our bodies function. And they are determined by our genes. And if those genes are working properly, then we can heal ourselves. And we see this when we're younger, we're just more capable of doing this. Our bodies are more capable, the communicating environment, which we now call the bioenvironment, is in favor of rejuvenation and regeneration. So if we're threatened by disease or injury, the cells send out distress messages, and these are picked up by our regenerative system, mediated through the white cells, which then send signals to those regenerative cells to get them to start working to heal. Now, healing occurs on a number of different levels. One is repair, and I see this as scarring, and the other is regeneration, but both are important. What we need to do is we need to, first of all, create an architecture of a base ground architecture of fibrin, blood vessels, which hold the cells, and then we need to populate that with cells. And what we see as we age is that the actual architecture is being set up, and there is less and less cellular population of that architecture as we get older. So we end up with more scar tissue, more fibrous tissue, and the intracellular matrix isn't being fully populated with cells. So what's happening is that fewer cells are there. So the actual regenerative part of the healing process diminishes with age. And the main reason for this is because of the change in the internal factors. And these are the factors that create that bioenvironment which direct our cells to work in a healthy way. And of course, external factors have an impact on this. So when we talk about internal factors and external factors, we can think about it in a scientific fashion as being genetic factors. So each of us are genetically different, and each of us respond in a different way. And then you've got factors outside of the body, which are environmental factors, which we call epigenetic factors, which change the expression of genes. So we can have a positive or a negative expression of a particular gene complex, which will give a positive or a negative effect on our bodies. Now, when we talk about regenerative stages, up to the age of about 35, most of our bodies are in positive regeneration. And that's because nature wants us to procreate. It wants us to pass on our DNA to the next generation. Now, beyond that point, it totally gives up on us and we start to age. So I call that the tipping point of aging. So that's when we start to age. This is where degeneration and degradation starts to overtake the regenerative side. And we notice this in how we feel. If we fall over, we don't bounce back as well. It hurts more. It takes longer to heal. Also, if we cut ourselves, we're more likely to get more scarring than regenerative healing that we get when we're much younger. So that's what I describe as the tipping point. Okay, next slide, please. As our scientific knowledge on intracellular communication continues to expand, It's driving a real revolution in regenerative medicine. And we used to get really excited about stem cells. And it was all about stem cells this, stem cells that. We all wanted to get on board and on board the train that advocated stem cells. And people were using the term stem cells inappropriately as well, when they weren't actually using stem cells to affect regeneration or healing. But the most important thing is the bioenvironment. Now, as we age, our cellular, intracellular, and intracellular communication deteriorates and regeneration slows down. And it's really the bioenvironment that determines how effective our cells work. And as that slows down, we see more and more effects of our environment, the epigenetic aging, the damage through super oxidative species, the damage through a poor diet, the damage through a polluted environment, poor water supply, damage through UV exposure. So all of these things and the damage that occurs through our own psychophysical well-being, the stress, high levels of stress can also cause cellular damage. So we see a deterioration. And if our immune system and our regenerative system isn't getting the right messages, or in the form it got when we were much younger, then that degeneration continues and we get actual cellular damage. So the response to assault and damage is inflammation. And a lot of people are very scared about inflammation, but inflammation is actually really important. And acute inflammation is an important part of the trigger to regeneration. It's chronic inflammation that we don't want. So once we get those messages over to our immune system, to our white cells, they then produce cytokines which settle inflammation, they activate the regenerative system, and then the cascade of regeneration feeds back all the way back to our stem cells. And I'm going to talk about stem cells in a minute as well, because stem cells in particular are able to read these messages, but only if they're there. If they're not there, the stem cells become dormant and they become quiescent. They don't lose their potency because once we reintroduce those messages, they'll pick them up and they'll become activated again. They can also recognize the environment that they're in and adapt to any changes taking on the characteristic of that environment. Now, there was a lot of interesting work done early on when 𝘱𝘃 from America were doing fat transfers, and they were doing adipose-derived stem cells, as they call them, but it was actually adipose-derived concentrated stromal vascular fraction. And this was being used to enrich fat, which was taken from the abdomen and transplanted into different parts of the body for reconstruction, we saw it for breast augmentation. And when you went back and looked at the actual fat cells that were there a year to 2 years later, they were indistinguishable from the organs into which they'd been implanted. So there is that adaptation of cells into the environment, which is great because there was always this fear that if you're taking fat from the abdomen and putting it elsewhere, it's going to behave like that fat from the abdomen and carry on doing so. But that's not the case. So as we age, the potency of the stem cell does not deteriorate. It used to be thought that it did. And indeed, if you read the hallmarks of aging, that's one of the hallmarks that's still quoted. But what we're finding out more and more is that that's not the case. It's a bioenvironment that changes, hence the responsiveness of the regenerative cells, including stem cells, will change. Okay, can we go on to the next slide? Okay, the wonderful thing about regenerative medicine is that it's never too late to turn back time. And this has been shown by a number of papers, and a number of scientists, in particular, the one I've quoted here, which demonstrated that a 70-year-old skin cell can be reprogrammed to go through regression and become akin to an embryonic stem cell. And this finding was a game changer. And they did this not by stimulating it in any other way than changing the bioenvironment and creating a very young bioenvironment. And each time the cell replicated, it regressed back to a younger state of itself. So that was really exciting. And it sort of opened a lot of doors to a lot of things that we're using in aesthetic medicine now to rejuvenate the skin and to regenerate the skin. You know, when we look at things like polynucleotides, we look at things like exosomes. There's a lot of excitement about exosomes. But exosomes are really pockets. They are envelopes in which we deliver the cytokines, and we can choose which cytokines we put into those. So these exosomes are the way that cells produce communicating pockets which go from one cell to another to pass on that message. So all cells lose potency over time, but the stem cells keep their potency. And the other thing that there was a lot of excitement about with stem cells was embryonic stem cells. Everybody wanted embryonic stem cells. Now, there are ethical issues relating to that, but we've got stem cells akin to embryonic stem cells in our bodies as well. And their abilities are very similar to embryonic stem cells. Yes, they're very few in number, and we don't find many of them. But once stimulated, they will provide cells for the next stage in the evolution to the end cell. So they're there for a reason. And just by increasing their number, we're not necessarily increasing regeneration. And the way I look at it is that if there's damage at one end of the scale, at the end cell stage, and that cellular population is diminishing or it's damaged, it's calling back for a replacement, then the messages go all the way back. And each cell line moves forwards. And the embryonic stem cells that we have, which are also known as immortal stem cells, they can replicate themselves and then they can differentiate to the next line. So they're there to keep that supply of cells coming as and when we need them. But of course, that communication has to be there. We're also now at a point where we can store stem cells, and this has been going on for a while. And we indeed, when we had grandchildren, we paid for stem cell storage. I really don't know how useful that is, other than storing genetic information. Yes, they can be brought out, they can be used, but from what I've just said, science has moved on from there, and we now know that if we change the bioenvironment, we can utilize the stem cells that are already in the body. Unless we have a situation, of course, like leukemia, where we've got to destroy a cell population, we can then use those stem cells to repopulate it. And we do that with bone marrow stem cells at the moment. So next slide, please. Thank you. So these are the 9 hallmarks of aging, and already they're becoming outdated because we're finding out more and more, and our knowledge is moving forwards very, very quickly. There's a lot of work done in cellular biology and cellular research within the universities, and we've just got to keep an eye out on what's happening and what's coming out. So these are changing, but generally these still hold true, and these are the changes that are happening as we age. Okay, next slide. Okay, so the potency of stem cells determines their potential and versatility to differentiate into a wider variety of cells in the body. Now, the end cells, for example, the keratinocytes, for example, all the end components of skin, because we're talking about aesthetics here, are very plastic in the way that they respond. They can, if they do replicate, they replicate into themselves. And certainly the keratinocytes don't replicate, they just die off and then they shed. So what we have is a whole line of cells in their evolution, which are providing new cells to replace the ones that have gone. And one of the things that is important to realize is that something as simple as exfoliation is a regenerative treatment. When we exfoliate, we're taking off dead skin cells, which means that the cells that are going to replace them are signaled, and they signal back to the cells that replace them and all the way back to stem cells. So when we do a peel, it's a regenerative treatment. When we do laser resurfacing, when we do microdermabrasion, even when we use products that exfoliate and stimulate, they are sending signals back. Now, biostimulation obviously is best when it's done autologously. In other words, your own cells are doing it. However, as we get older, these communicating proteins diminish, and now we're able to introduce peptides or bioidentical peptides which start the signaling process. But after a period of time, what we want is we want our own cells to take over that process and perpetuate that process for a length of time. So we get that bioregeneration ourselves as an autologous process. So a lot of the treatments I see as kickstart treatments. We may need to use them over, 4 to 6 weeks in order to get things started. But once they're started, there'll be a knock-on effect where the cells are doing it for themselves for a particular length of time. It's not going to be forever because the aging process continues. So let's have a look at these different generations. So we have totipotent stem cells. These are there from day 1, from fertilization, up to about day 4 of fertilization, which is up to 16 cell size. Now, beyond that, you get differentiation. And the differentiation then is to pluripotent, where you've got the blastocyte developing. That's 32 cell, up to 5 days. Now, the pluripotent are not as potent as the totipotent. They don't make absolutely everything that's required for life, but they make enough that is required for the fetus. And as a fetus develops, then we've gone on. Can we go back a little bit to the last slide? There we go. So once the fetus is developed, the gastrula, from 15 days onwards, then we've got multipotent. And these are the embryonic stem cells. And then their potency reduces as we go along, okay, down to precursor or progenitor cells in the fetus and onwards. Next slide, please. Okay, so I see stem cells like generals in an army. They recognize the environment by reading the CD markers of the cells within the organ, so they can specialize to that organ. They pick up on cytokines that act as distress signals from the stressed cells, so they can start to respond. And they then send out signals that will then direct their armies of regenerative cells and the immune system to start to regenerate. They send signals to the immune system to stop shouting so loudly, to settle the inflammation, so a chronic inflammatory condition doesn't occur. And then the regenerative cells start to do their work. And each cell has its own function, obviously. Now, they have the ability to replicate without loss of potency, and also the ability to differentiate into the next stage of specific cells. Now, we have also seen by that research that I quoted earlier, that by creating the correct bioenvironment, we can get them to move back along the line of evolution. In other words, to devolate to a younger, more potent type of stem cell. So the majority of the action through immunomodulation and cell signaling we get by improving the intracellular communication and enhancing regeneration. And this is what we're going to be talking about when we talk about nanografting and micrografting. Okay, next slide, please. So what we're talking about really here is not stem cell treatment. Stem cells are treatments, and stem cell research uses propagated stem cells, which can be autologous or allogeneic, in other words, your own, or donated, either from fetuses or from umbilical stem cells, to look at their properties and their action in various conditions. What we're talking about is autologous use of tissue, where we can get what we call the stromal vascular fraction. And this is important. It's important to actually differentiate this from stem cells. It's a cellular treatment, however, it's autologous, and we're not manipulating the stromal vascular fraction beyond what it does normally to any significant degree. So where can we get stromal vascular fraction from? Well, there are specific areas and easy to access areas. Well, skin is very easy. Bone marrow is another area. Of course, adipose tissue is very rich in stromal vascular fraction cells. And then we've got the tooth pulp, which is also very high. I would reckon per gram of tissue, tooth pulp probably carries the most, and then it's adipose tissue after that. And then bone marrow, and then skin. Okay, next slide. Thank you. So, easily accessible stem cells and stromal vascular fraction. Where can we get it? Well, stem cells we can get, as I've said before, from embryonic, aborted embryos, and placenta and umbilical cord. These are highly regulated by the Human Tissue Authority, and there is a huge amount of ethics that goes around what we can do and what we can't do with cells are not our own, which have been collected. And then you've got adult, which can be autologous. The regulation is less because it's autologous. You have control over your own, and how you consent for that tissue to be used is up to you. So the adult can be from skin, tooth pulp, blood, bone marrow, and adipose tissue. Next slide, please. Thank you. So most of the cells of the solid organs in our bodies are held in connective tissue. It's a stroma of connective tissue, which also contains blood vessels with pericytes, regenerative cells, immune cells, precursor, blast cells, and small number of stem cells. And I emphasize that because we only have a small number, and we only need a small number of stem cells because they can self-replicate and they can differentiate. Now, there is a time in history, an important time in history, a point in history, and this was 12th of October 2002. After the Bali bombings, 209 people with horrific injuries were admitted to A&E, of which 28 people with burns that covered over 90% of their bodies were admitted to the Royal Perth Hospital in Australia under the care of Dr. Fiona Wood. She was the head of burns unit on call at that time. She was also involved with research looking at a liquid cellular skin graft. And because these people had such great burns, the emergency was to try and close and stabilize those burns. Otherwise, there was a huge risk of death. Now, the risk of death would have been really high in these patients because of the degree of burns. However, she was able to save 25 out of 28 people by using her new technique at that time. And this was then released as RECELL. Now, RECELL is effectively taking small part of the skin. It's a split skin graft at the dermal level, the mid-dermal level, where you catch the junctional cells. These are the cells which create the skin, and they also contain regenerative cells. They're then trypsinized and enzymatically broken down and separated and washed and suspended in Hartmann's or in normal saline, in physiological fluid. The burns were then sprayed and covered. There was a primary dressing there to hold things together and a secondary dressing put on. And what she found was that within a week, those wounds closed and skin grew across. Now, the normal architecture of skin wouldn't obviously be created by this because what these cells are not doing is creating complex structures, like follicular beds and sebaceous units and things like that. But what they did was they were able to close it, and there was less scarring, and any scarring that was less was more flexible and mobile, so that it was more functional repair and regeneration. And this again was landmark because it showed what could be done. Now, she got into trouble for this, but because she saved 25 out of 28 people, that was unprecedented. I think her case was dropped by her governing body because it was still in research and she had to do what she had to do to save the people. So when the cells are extracted from the stroma, they become activated. But it's important to realize and understand that we shouldn't extract all the cells from all the stroma because there's an increased risk of cell death. They go into a process of cell death. So they've got to be used quickly and reintroduced into a stroma. Next slide, please. Okay. So we've already covered this. Regenerative treatments seek to replace cells, tissues, or organs that have been damaged by disease, trauma, or congenital issues. Also, aging is damaging tissues, so it can be recognized as a condition. The tools used to achieve these outcomes are tissue engineering, cellular therapies, medical devices that harness and concentrate growth factors. So it isn't just medicine that's doing this. It isn't just cellular biology, but we have to rely on all areas of technology as it improves, including AI, as we learn more and more feedback and get results and feedback and develop algorithms as to which are going to be the best treatments for certain conditions. So it's a relatively new field and it's really exciting. It's probably the most challenging field, but it's addressing the most challenging problems we have. And some of those problems we've created ourselves through medicine, through science, in the traditional way, by extending life. Next slide, please. So what I'm going to do is go on to talk about the technology that's been involved. Now, there are lots of different technologies. This is what we're using at the moment for our nanografting. Next slide, please. So we talk about mesenchymal stem cells, but it's not just stem cells. It's mesenchymal stem cells plus the side population of regenerative cells and supportive cells that are present around blood vessels within tissues. Their sole purpose is there to get involved with regeneration when some damage occurs. So we're already equipped with everything we need to regenerate the tissues. The only problem is that the communications are getting less and less, and they're getting poorer and poorer as we age. When we're young, a slight injury will trigger this regeneration, and those cells will come into action and do their thing. Now, the other thing that these side populations have is what we call a niche environment. This is a bioenvironment that's created by the supporting cells, which allow them to survive within the tissues that they're found. So where do we find them? We find them in bone marrow, we find them in peripheral blood, and we find them in adipose tissue. This is specific to our profession. And of course, dentists will find them in tooth pulp and things like that. So, you know, if you've missed out on storing stem cells, the best time to store them is when your children lose their teeth. That would be another opportunity for you to take stem cells and store them. Okay, next slide, please. Right, so adipose tissue and stem cells. There's been a huge move in aesthetic medicine for liposuction and getting rid of fat, but our fat is really liquid gold. It contains the source of regeneration for our bodies. The main features of this is that it's easy to access. The sampling isn't necessarily painful, and the sort of aftercare is quite simple. It's not very invasive because it's a subcutaneous, gentle lipoaspiration, and it is rich in mesenchymal stem cells and regenerative cells. Next one, please. Okay. So 1 gram of adipose tissue will give about 5 times 10 to the 3 mesenchymal stem cells, which is around 500 times more than 1 gram of bone marrow. So it's extremely rich in stem cells. Next slide, please. But we're not just talking about stem cells. What we're talking about is stromal vascular fraction. And I've got to get this drummed in to everybody that I teach, and even my staff, because they say, oh, I want a stem cell facelift. Well, it's not a stem cell facelift. It is a regenerative facelift. It's a cellular regenerative facelift. So what have we got? So the fraction of the cells composes of, obviously, mesenchymal stem cells. And the different sources will have different CD markers. They'll be specific to where we get it from. So there are stem cells, but the amount of stem cells is tiny. It's about 0.12% of the cellular material within that aspirate, within the cellular part of that aspirate. So mesenchymal stem cells are one. Endothelial cells are, again, some other cells. You've got smooth muscle cells, pericytes, and these are interesting cells that we've discovered around the arterioles, and these are involved with neovascularization. There are leukocytes there and there are platelets there. And there will also be some blood cells because of the trauma to the blood vessels, but that depends on how we harvest it, and I'm going to talk about that just in a minute. Next slide, please. So the stromal vascular fraction, it's a tridimensional scaffold wrapped in a vascular net where cells live and exchange messages. And that's really important. Remember, I was talking about bioenvironment. That's all about communications. And that's where cellular intelligence comes from. And they then participate in how the tissues regenerate. The side populations are those regenerative cells and supporting cells that exist in a niche bioenvironment. And that bioenvironment is different to the bioenvironment of the other cells. And that just is there to allow those cells to survive in that side population. Next slide, please. So vasculogenic potential of adipose tissues. So this slide just shows tissue sources for mesenchymal stem cells, and then the mesenchymal stem cell lines, and also cells that are able to convert to mesenchymal stem cells. Now, there's been a big issue because cancer cells can convert to mesenchymal stem cells. There's been a big question as to whether once they've converted to mesenchymal stem cells, do they actually go back to cancer cells, and does it increase risk of cancer? And the research so far has shown that that is not the case. There are other factors involved with cancer cell development, but cancer cells can escape their normal plastic function and become quite elastic in the way that they replicate and change. So there are certain cancers that we've got to be careful with when we're dealing with cellular regeneration, but that's for another topic. So pericytes are connective cells which surround contractile capillaries, and their function is to come and be involved with neovascularization, but we also find that they can evolve into mesenchymal stem cells as well to add to that population. New paragraph? Sorry, next slide, please. Okay, so isolation from lipoaspirate. So once we've taken the fat, we need to isolate the mesenchymal stem cells and the stromal vascular fraction. The most widely used technique in research and historically has been enzymatic isolation. However, there is an issue with this in that we're using enzymes. These enzymes can also damage the cells that are being separated. But also, once we disaggregate those cells from their stromal network and connective tissue, they start to die. Okay. The other ways of doing it is by non-enzymatic isolation, and that can be by agitation. And everybody's come across lipogems where you've got small ball bearings which knock the tissue around and disaggregate the cells into small pearls of fat cells around a connective tissue matrix. And then there is the microfragmentation, and that's the technique that we're using. Next slide, please. So microfragmentation, with the agitation, you can get physical trauma to the cells. It's difficult to know at what stage the endpoint is, and you only get so much out of it. But with microfragmentation, I find that it's more predictable because what we're using are structures. We're using fine mesh, which is fixed, and we're using a technique which is fixed, which gives us a very consistent outflow of what we're getting. Now, we know that reducing the fat into small clusters will increase its survival, because its survival then is dependent on the tissue that you inject it in, and the oxygen and the nutrition is delivered via diffusion. And diffusion will only penetrate 3 millimeters from the surface. So by creating a small nano particle, we're increasing the ability of that to survive, because it's getting diffusion of nutrients and oxygen without vascularization right to the core of its substance. Now, that can then be used as a regenerative medicine, if you like. It's a human medicine that we can use to stimulate regeneration with larger droplets, so micro droplets. Now, the thing about micro droplets is it's important that you have a degree of stress, cellular stress. Now, micro droplets are up to 0.9 millimeters. That means the core of those, the 6 millimeter diameter core, will be under stress, and some of them will become necrotic. But in undergoing that stress, they're releasing the cytokines, which are signaling to our nanograft to start that regenerative process. And that's a really important concept to take on board. And that's why we mix the two. I always mix nanograft with micrograft. And then the cell survival is much greater. And the nanograft is then supporting and protecting the actual death of cells within the micrograft. So the clusters are really easy to use. Because they're so small, we can use them for skin rejuvenation. They can be used for all different types of treatments, and we'll come to that in a minute. So the problem is that if you take the cells away from their structure, their infrastructure, and they are floating around without the infrastructure, you've destroyed the niche environment, and those cells start to die quite quickly. So they're at risk. So that's why I think this sort of technique is good, because it retains that basic matrix in which the cells are contained. So what we're doing is we're creating nano communities of site populations. Okay, next slide, please. So this shows the microfragmented adipose tissue, which is rich in pericytes, and you can start to see the vascular changes that occur with that over time. Next one. This is a system that we use. It's very simple to use. It's based on an old system which 𝘱𝘳𝘰 brought out as part of their evolution, which we used when it first came out. We loved it. Sadly, 𝘱𝘳𝘰 went back to the States and back to research because they were calling it stem cells. Now it's come back out again in a refreshed form. Not only the colors are better, but the sort of functionality and the ease of use is much better. So what does it do? Its main features are microfragmentation, tissue purification and cleansing, cleaning of the tissue and taking away the sort of fibrous tissue, separating it from excess fibrous tissue, from blood cells, and from unnecessary white cells, and also from the oil that's produced through the trauma to the fat cells. There's no centrifugation that's required, and minimal cellular stress because of the gentle process that's used. And we get high quality cells each time. Next one, please. Okay, so the adipose tissue microfragmentation, purification, and washing occurs in a closed system. So, and it's very easy to use. So you can use this system and be the main operator with only, you only need one assistant, just a runner, to get the things that you need. There are two filtration systems within one. You get microfragmentation, purification, and washing of the adipose tissues, and it separates, and we'll go through how we use it. There's no centrifugation. The problem with centrifugation is that you get a pellet at the bottom which contains red cells as well, which can interfere with the function of the actual site population cells. There's minimal manipulation. It's a completely closed system, and the complete kit has everything you need to carry out the procedure. All you need to do is add the physiological fluid, which can be Hartmann's or normal saline. Next slide, please. Okay. It's a very quick process. You can process up to 400 mils of adipose tissue in about 10 minutes. Very simple to use. We will be doing training. I've got a training session lined up. We'll talk about that at the end. There'll be a reference to that. And if anybody wants to go on the training, we can organize things. Clive from Rosmetics is organising it. I'll be doing the training, and you can talk about that later. Again, it's being compared to centrifugation. So there's a lot of saving of time and cost. You don't need any expensive centrifuges, which count cells and things like that, to be there. So there isn't a large piece of equipment taking up space in your minor ops theatre, and you don't need the regulatory framework that goes around having centrifuges and equipment. It's an all-in-one system. It's got everything you need. Again, it preserves the biological properties of the site populations and the niche environment. So the outflow is just much higher quality, and we see really good results with it. And it's really easy to use. Next slide, please. Okay, this is showing the system. As it's plugged up, you can see that it's plugged up to some saline or Hartmann solution. You inject the lipoaspirate where it says lipo in, and then you process it, and we'll show you a video on how you process it. And then you've got purified stromal vascular fraction and fat, and or nanofat and microfat down at the bottom, which has been washed and cleansed, and you can aspirate it down at the bottom. Next slide, please. So this shows the two different systems or filtration systems and how they work. The fibrotic tissue is trapped in the upper part, so you don't get blockages of your needles when you're injecting it. Most of the blockages occur because of surplus fibrotic tissue, and then you get the microfragmentation and purification in the bottom part of the filter. Next slide, please. Okay, so again, the standard kit has everything you need to aspirate the fat, to infiltrate, to aspirate. All you need is some anesthetic, you need some saline, and then you're good to go. You've also got a little microneedle to inject the fat with, and you've got syringes. You've got absolutely everything you need in that kit. Next one, please. Okay, so the beauty of this is that you've got aspiration can be from the abdomen, from the flanks, from the glutes, and from the thighs. It's easy to do. The important thing about the aspiration is it's not liposuction. We're using a very fine cannula. We don't even use a scalpel. I use an 18-gauge needle to introduce cannula with, and it's introduced into the subcutaneous fat and the subfascial fat, and it's outside of the body cavity. And the important thing to realize is that the actual syringes that are designed to clip and create the vacuum to less than 300 millimeters of mercury, above which you get more damage to the cells and you get more oil produced. So everything has been thought out properly for you. You don't need to really have to think about what pressure do I do it at, how much do I pull. You just pull and clip and you're ready to go. Next one, please. Okay, this just takes you through the process. There is a paddle that you just use to move up and down. The fluid moves up and down, and the tissues move themselves into the appropriate position once they're ready. And after 10 minutes, you're ready to take it out and to use it. Next one, please. So what is it used for? Obviously, orthopedics is a big field in which this is used for osteoarthrosis, for chondral injury, to various joints, tendinopathy, lower back pain, soft tissue injury, but it's also used for facial-maxillary surgery, spinal surgery, genitourinary rejuvenation, and after surgery as well for healing. Orthopedics we've already talked about, plastic and reconstructive, that's where we're using it. Then it's used for wound healing, and it's an excellent media for wound healing, and you can create a dressing with this, leave it on, double dress it, and then the wounds heal absolutely beautiful. But post-surgical wound healing as well. And then it's used for pain therapy again with orthopedics and musculoskeletal. Next slide, please. So again, the main features are that it's simple, you get micro fragmentation, you get very little trauma. And here is a video that shows you the whole process. So if we go on to the video now and start that. It's a 2-minute video. Wonderful. Okay. So again, it just shows the system is self-contained. Okay. It is carried out in a sterile environment. So you need a proper minor procedures theatre where you can sterilize a patient properly. You can gown up yourselves. This is where you get your aspirate from. First is we anesthetize the area using a 𝘕𝘓 or a modified 𝘕𝘓 solution. Again, when you come to the training, we go through all of that. It's only local anesthetic, patient is awake. Then we use a special syringe to aspirate with. It usually comes out yellow. Remember to wait a good 7 to 10 minutes before you aspirate. The aspirate's then. You open the clamp with a saline or Hartmann solution, you let that run through. When it's full, make sure no bubbles are in the actual kit, and then you inject the fat in. You do up to 400 mils in any one go, and then we use a paddle just gently to move the fluid down. You can see at the waist, the blood and the oil is going, and then you flush it again and do the same. Once it's all done, you can aspirate and you're ready to go. You've got a natural filler. Okay. You've got, and if you're using nanograft, you've got the equivalent of the stromal vascular fratction, which you do directly into the skin, into the dermis, and into joints. Thank you. Next slide. Okay, that's great. So we have got training dates on the 19th of November. That's the next training. If anybody is interested, please get in touch with Ros Medics, and Clive will sort things out, or you can get in touch with Anna, and I'm sure Anna will pass your details on. Thank you.
I will definitely do my best. Thank you so much for that, Dr.
How are we
Khan.
for time?
Really interesting. We're doing okay, but we have lots of questions. So let's crack on with some questions, shall we?
Right.
To start off, there are some questions about the training. Is training only available to doctors, or is it also available to dentists and nurses as well?
Ask Clive. I'm going to be training doctors. Dentists can use this technique for rejuvenating the gums. So I suppose, you know, dentists do operate on the face. So I think they've got to talk to their insurers and their bodies to see if this is something that's appropriate for them. But mainly it's for the doctors. It'll be open to dentists. I don't think it's open to nurses at this point because it's a surgical procedure, and it requires, I think you need to be on the GMC, registered to do that at the moment. Again, talk to your bodies and find out if this is something that, you know, they will credentialize you doing. If it is, then we can look at that.
Fabulous. And then we have a couple of questions around the procedure a bit more. Many clinics in Portugal use the micro equipment to collect fat. Does the doctor collect fat manually for gluteus filler procedures, for example?
Say that again. Many
of the Portugal clinics,
yes,
the micro equipment is
yes.
What's to collect fat. Does the doctor collect fat manually for gluteus filler procedures?
Yes. Yeah, I think you've got to be very, very careful with the fat that you collect. But for the gluteus procedures, you know, you've got high risk there because of the vasculature and how we're dealing with lipofilling of the actual buttocks. We're not the gluteal area. We're not filling the gluteal muscle. You've got to stay well away from that. And it's got to be done under ultrasound control. Again, there will be training support for that, for people who are doing that.
In children with burns, from what age is treatment with mesenchymal therapy indicated?
Well, we are adults only, so we don't see anybody under the age of 18. But for burns, anything that closes a burn quickly, we've got PRP that does that. I think that you can make dressings out of PRP, and that's being used more and more. As far as mesenchymal stem cells are concerned, that's still at the research level, but something like this in a burns unit could be quite an asset.
Also,
but don't forget, it's going to be autologous, and taking fat from a child is going to be more difficult. They don't have as much excess fat as we do as adults.
Then I have a question. In older people from the age of 75, mesenchymal stem cells placed in the belly, for example, are just as effective as if the same patient were 35 or 40 years old. Is that?
Well, the stem cells are, but the bioenvironment isn't. So it's about stimulating the bioenvironment. So, there are things that we can do to prepare older patients, but once we take them out, they will become activated. Obviously, not as many because the bioenvironment isn't that good. But each time you do it, you're stimulating that bioenvironment, and it's all about biorejuvenation rather than stem cells. So if we can create a much younger bioenvironment, then yes, they would be as effective, as shown by that paper where 70-year-old skin cells can be regressed back to mesenchymal stem cell activity.
Again, about stem cells, will these stem cells be helpful for chronic pain conditions, is the question.
Absolutely, yeah.
Sorry, more questions, still going. The body's absorption rate varies from person to person. What's the average absorption rate of mesenchymal by the patient's body?
Absorption, that's a difficult question. There isn't an absorption of cells. The body will absorb fluids, it'll absorb liquids, but it's not going to absorb cells. So what we're talking about is cell survival. And once introduced into the body, everybody has a different, obviously, the older the person, the less the effect, but you're going to get an effect, and you may need to do more than one treatment to get the optimal effect because of the cellular activity, because of a poorer bioenvironment. And what we're doing is we're improving the bioenvironment. The retention or the number of stem cells or the survival of stem cells is really, or the stromal vascular fraction to be more accurate, is really down to the technique and how we aspirate it. So if we do high pressure aspiration, less of them will survive. So clearly fewer will be injected in an active form, and also how we process it as well. And as I've already said, the more we mess with it, the less of them will survive. So try and stay away from enzymatic or chemical processing, stay with mechanical but gently, and try and maintain the integrity of that population, that side population structure.
We have just had a question on how you can improve the bioenvironment. So I think you've just given an answer to that. I know you said there's no absorption rate, so potentially this question needs tweaking from that was sent in, but it came in before that comment. So the question we had was, is the absorption rate the same in all parts of the body? If the mesenchymal was applied to the face, the body's absorption rate will be the same if the mesenchymal is injected into the breast. In other words, depending on where it's applied, does the body's absorption rate change, or do they remain the same?
I think what we're talking about is regression of fat cells. People, when we do fat transfers, not all of the fat cells will survive. And the average retention of volume, whether it's the original fat cells that we've injected or whether the pre-adipocytes have turned into fat cells in that area and taken on the sort of characteristics of that area, there's been research to show that the original cells change. They're not the same. So it may be that none of them survive. But what we're doing is we're creating a bioenvironment around the precursor cells, which will then become those fat cells and replace the ones that die off. But it really depends on the vascular bed into which we're injecting. Now, what I like to do is improve that vascular bed before we actually do the injection. You can do that by various techniques. You can do it by microneedling, because you're causing trauma, you're causing neovascularization and repair. You can do it by microneedling with injecting PRP, and that also increases the blood supply. So the survival is totally dependent on how quickly we can get the blood supply to living tissues and the fat cells.
So quick return to the question on improving the bioenvironment. Specifically, how would you improve the bioenvironment in a 70-year-old?
Well, you can do it by pre-treating. So there are lots of things that we can do to pre-treat somebody. So what we're talking about is looking at their physiological health. So, you know, it comes down to making sure that they're the healthiest they can be. If they're on any medication, that might be interfering with how their bodies work. We can use PRP beforehand to improve the bioenvironment. We can use exosomes with the right cytokines in. We can use polynucleotides. You can use peptides. The bioenvironment is improved by improving their hormonal status. So if they're diabetics or if they've got metabolic distress, we correct that. And so the older we are, the more we have to do to support it. But simply by injecting activated, primed stromal vascular fraction, we're changing that bioenvironment. So somebody who's older may need 2 or 3 treatments to get the ideal result that we can get with them, compared to somebody who's in their 40s or 50s that might only need 1 treatment.
We have a final question, and that's how many days does it take to heal or repair any pathology in orthopedics or other pathology, I think it says.
Okay, so we're talking about how long does biorejuvenation take? So the key to that is that the pain diminishes very, very quickly, because the cytokines that actually control inflammation are almost within 24 to 48 hours. People will find that they are much more comfortable very quickly. The regenerative process starts at about 3 weeks. So you have a change in the bioenvironment, you have a progressive activation of your bioregenerative systems, and then the bioregeneration actually occurs, we start to see it in about 3 weeks, and it carries on for 3 to 6 months. So you will start to see an improvement. And because it becomes self-perpetuating after a while, that improvement may carry on and taper off over about a year or so. So you might still see improvements a year down the road. And then you start to age.
Amazing. Thank you so much for your time. That I can see there are more questions coming in, but we have ran out of time, unfortunately. But I'm sure that if anyone would like to ask more questions, they can ask it on the training sessions or directly to both of you. Which is the best way to contact you guys?
I think Clive would be the best. You've got the details there.
Amazing. Well, thank you very much for your time, everyone. Have a wonderful day, and it's been really interesting. Speak to you soon.
Thanks. Good to see you.
Bye.